Hello, everyone, and welcome back to the MedBoys podcast. Today, we're speaking to Dr. Michael Wiggins, a writer, musician, cataract and glaucoma surgeon who has taught ophthalmology residents for over 20 years. How are you doing today, Dr. Wiggins?
Doing great. Thanks for having me.
Thank you, Dr. Wiggins. I want to start off just by asking you, since you're doing a lot of things and you have been doing a lot of things for the past so many years, your schedule must be really busy. So could you just walk us through a day in the life, of your day?
Uh, sure. I've kind of done everything from private practice to working in universities to federal work. And right now, I guess a day for me, I get up about 5:30, and I'm at the hospital at 7, and then I'll work a 10-hour shift. And during that time, I'm teaching residents in the clinic, and one day a week I'm in the OR and I'm teaching surgery there. And that's pretty much every day.
So, Dr. Wiggins, what actually got you into ophthalmology and surgery in the first place?
um well, you know um down in, I don't know what it's like where you guys are, but down in the South, when anyone starts a story with "so there I was," that's going to be a really great story, right? So I don't know if I have a really great story, but there I was, and I was 12 years old, and I was working in a hardware store. It was my first job. And so I don't know if you fellas know what ready mix cement is, but it comes in this 80-pound bag and you mix it with water and it turns into concrete. Anyway, I'm 12 years old. It's in the middle of July. And my job, because the hardware store didn't have a forklift, my job is to go out to where the delivery truck was, pick up a bag off the pallet, walk it into the warehouse, and put it on another pallet. And there's three huge pallets. So here it is. There's no air conditioning. It's 90 degrees outside. I'm 12 years old carrying these 80-pound bags. Halfway through, the owner told me to stop doing that and go for my first eye appointment. So I walk across town, in the blazing sun, and I'm dripping in sweat. And I go to the eye doctor's office and I open up the door and I get hit by this blast of air conditioning. It was like the greatest feeling of my life. And so I said, I don't know what this guy does, but I'm going to have this job. And that's my story. Now I'm an ophthalmologist.
That is a very interesting story and very honest. I think something like that, I think it's so simple, but it inspires you for the rest of your life. And would you say you've been happy with that decision from your childhood?
Oh yeah, absolutely. Definitely going through medical school, seeing all the other fields. They're great in their own way, but nothing touches ophthalmology. It is absolutely the best field.
I feel
Yeah.
like many people up here in Canada feel that way as well because it's probably the most competitive specialty to match into in residency here. And before we get into all that stuff, I had a question for you that's more for the general public. So, as an ophthalmologist, is there something you feel that people, everyday people, should be doing to take care of their eyes for the future? Because I don't feel there's that much information out there about all of this.
Uh, yeah, it's a great question. So, as a glaucoma guy, I would tell you that if anyone in your family has glaucoma, it's by and large a hereditary disease, and 15% chance that if a first degree relative, meaning a sibling or a parent or your kid has one, has glaucoma, then 15% chance that you do too. You need to go have your eyes dilated. If someone's doing an eye exam, but they're not dilating your eyes to look inside, that's a red flag, and you need to have that exam to look for glaucoma. So that would be one. Two is that as a society, we don't wear sunglasses near enough. And that's what's going to prevent cataracts. It's going to prevent cancers around the eyelid. So wear your sunglasses. And, smoking causes cataracts quite a bit too. So it turns out that when you look at all the research, smoking does nothing good for you. Who knew?
And I want to ask you about your writing career. So last year you published Magical Arkansas Tales, followed by the Sugarfield Sugar Cookie. This year you published the second edition of an ophthalmology textbook, Clinical Optics Made Easy, and you have another novel due out this summer, Letters of the Arkansas Traveler. Could you tell us a little bit about these books?
Absolutely. Thanks for asking. So I love to write, and I've taught optics for 20 years. And when I was teaching optics to residents and students, they would ask me to give them handouts. And so I said, well, if I'm going to give all these handouts, I might as well, kind of write a book about it. And so we put out the first edition, and that did really well. And then it called for a second edition, which we just did. But, medical writing is its own thing, and it's very restrictive in that you have to, every sentence has to kind of be perfect, has to follow the facts exactly. And so I really wanted to get out of those boundaries a little bit and do some creative writing. And so I got into the fictional world of writing novels. And so I was writing this novel called The Sugarfield Sugar Cookie, which is the story about a kid that is really kind of down on his luck. He's from a broken family and he's poor, but he really wants to get out of that and better his life by becoming a doctor. And so he's going to become a physician no matter what. And nothing's going to stop him, even if it's crossing moral, ethical lines, which you should not do. But in this case, he does. And so he's going to college trying to make that happen. But it seems like everything he does to make that happen, the universe just smacks him and knocks him back down. And he's got to get up and start all over. And at the same time, there's another kid from a small town at the same college, and the universe just loves him and everything's breaking his way. And it's like med school's being handed to him on a silver platter. So, that first kid, he's not going to like that at all. And he's going to try to rectify that situation. And so it's really this funny story that goes from college to what it's like to be in med school, to what it's like to be an intern, how residency is. And so it was really a fun book to write. But as I'm writing that book, my 9-year-old wanted to read it, but I couldn't let him because, it's a book really for adults. It's not appropriate for 9-year-olds. So I wrote a story for him, a kid's story. And then he read it and told me everything that was wrong about it. Because, it's an adult writing about kids and it's not a kid's writing about kids. And so he and I got together. This was back during COVID. We would take walks every evening and hash out these kids' stories. And so all of a sudden we have this collection of kids' stories. So we published that, and that's Magical Arkansas Tales. And then I don't want to belabor this. I know you want to talk about how to get into medical school, but the last thing that we have coming out is Letters of the Arkansas Traveler. And so this is an interesting thing. One day I was in the clinic and one of our diagnostic machines broke. And so the resident came and said, Dr. Wiggins, this OCT machine is down. We can't look at the retina. I'm going to have the front desk staff cancel the clinic for today. And, I'm a dinosaur. I came from the time before we had all these machines. I came from before we had electronic medical records. And so I said, no, let's grab a lens and I'm going to show you how to do some physical diagnosis exam things that I don't normally teach you because I don't have to, because we have these wonderful machines. But I should obviously be teaching you how to do this. And so I started thinking, maybe we're not teaching our residents kind of the old ways anymore because we don't have to, but maybe we should. So I wrote a novel about a modern day ophthalmologist that gets knocked back to 1950, and all of a sudden he's got to do that. And so he's got to figure out, how can I practice without these diagnostic machines, without antibiotics, without the sutures that I'm used to in the operating room, without lasers and all of these things. So it's kind of a fun story to see how he does that. So I kind of took a year and I read medical textbooks from that period to learn how they used to do things. And it turns out it wasn't a whole lot different. They had a lot of innovations. Those guys back in those days were really smart. So that was a fun book to write too.
That's very wonderful, Dr. Wiggins, and we'll be sure to sort of read those books as soon as they come out, especially the Sugarfield Sugar Cookie book. I find that this premise of that book is actually very, very interesting and very relevant to university students looking to pursue medicine in the future. It's like more of a sort of a bittersweet book, in my opinion. But moving on, would you say that you were always sort of a creative writer, or did your medical career maybe inspire you to become one? Because I know that creative writing is something that is essentially very, very taxing on the mind because of the fact that you're coming up with different stories or different characters to write about almost every day. So, what's your sort of stance on that matter?
Actually, I think creative writing is a release. You know, as a physician, you have to make all of these decisions, and there's all of this responsibility. And, you know, it's really a lot to go through on a day to day basis. But when you can start writing and you control the universe and what's going to happen, it's just, it really frees you up, and it's a lot of fun. But to answer your first question, no, I didn't start out that way. I was more of a medical writer. And so I wrote a lot for the medical literature, doing research and things like that. But again, it's a restrictive way of writing. You're just writing the facts. You're not putting you in there so much as you're reporting. And so I really wanted something that would allow me to kind of get out there.
And I feel like I can relate to that on a very personal level. I feel we kind of do that through this podcast or through our videos because it's a completely different way of looking at things. And it's like medicine sometimes can be based on criteria, based on checklists. So because of that, it can often be very cookie cutter. But then when you get to expand your mind and see all these other things, it's better for medicine as well, I feel. You talked about you having 10-hour shifts, and I'm sure those were a lot higher when you were in your residency years and when you were more junior as a doctor. And you've still talked about all these other things that you've done on the side. So how were you able to make sure that you put out time for your hobbies and then also make sure you devote time to your friends, family, and everything else that goes on in life?
Golly, I have no idea. No, I'm just kidding. um, you know, you have to make time. You know, your family has to come first, obviously, and you make time for them. And then you have to make time for you. You have to find something that brings you that unadulterated joy, and you've got to do that, or else you're just going to burn out. You know, and I don't know if it's worth saying, but I don't see myself as an ophthalmologist. I see myself as a person who happens to do ophthalmology, and I do these other things because I'm me. You know, there are lots of us out there that see ourselves just as a doctor 24 hours a day, and I don't think that's healthy. I think you've got to be a person first. And so you just got to make time, just squeeze it in wherever you can. You know, for example, I kind of quit watching television mostly to kind of do all these other things. And it was a big change in my life, just not to sit there in front of the TV anymore, but to make sure that I was doing something constructive, something that expands your mind.
I also want to ask you, Dr. Vaughter, who we were in contact with, and she was also on the podcast. She's been advocating a lot for medical school residents and also doctors as well. And one of the biggest things that she's advocating for is doctors not getting enough sleep. So I want to ask you, just on a personal, how many hours of sleep do you average, or has it gotten better, or is it the same as you were in your residency years?
That's a great question. So way back in the old days, again, I'm a dinosaur. At least in the US, we have what's called the ACGME, and they have these rules on how many hours you can work. But back then, they were just getting going, and they just had recommendations, which no one followed. And so you were working 100-hour work weeks. And, you know, that was definitely my intern year. And I can't remember much of that time of my life. You know, I've had a great life. I'm not complaining at all. Every year of my life has been better than the last, except for that intern year where they had us working 100-hour work weeks. And I was so fatigued the whole time. I just really have no recollection of that year. And it became better as a resident, and certainly better out in private practice. And now I'm not remembering your original question. You were asking me about fatigue. So the current rules from ACGME now are strictly adhered to. And so fatigue really does make you make poor decisions. It doesn't allow your brain to fully function. And so, you know, it may sound old, but I'm in bed by 9 o'clock every night. It doesn't matter. I have to be, or else I just can't give my patients the brain power that they need, that they deserve.
You're absolutely right about that. And I wish that, more medical students, more physicians would actually take that perspective into account. Whereas, sleep is not just for the betterment of yourself and your own mental health, it's also for the betterment of your own patients to make sure that you're attentive at all times when you're talking to them and giving them the care that they deserve. So I think that's a great perspective to have, Dr. Wiggins. And I'm sure a lot of the people that are watching will hopefully adopt that perspective. And just touching more on exactly how you provide care to patients, could you tell me a little bit about some of the procedures that you do on a day-to-day basis, and maybe some of those bread and butter cases that you might encounter very frequently that you could elaborate on within the confines of confidentiality, of course?
Sure. Um, Clinically, I see mostly glaucoma. I do see cataract patients. And then surgically, by far, the most common surgery, really likely the most common surgery in the country, is cataract surgery. And then there is a lot of glaucoma surgery on top of that, but the cataract surgery far outnumbers it. But the nice thing is that when you fix someone's cataract, oftentimes you're lowering their eye pressure, which is a treatment for glaucoma at the same time. And so it's kind of a 2-for-1.
And I feel like I've personally seen the impact of cataract surgery. I think it was like 5 or 7 minutes long in my grandmother's case, or maybe 15 minutes total. But then from when she went in to when she came out, obviously she couldn't see from that eye that fast. But then the difference that it made so fast was truly amazing. And that gratification that you would get by doing that, I feel is something that's really important in the career, because there are many specialties where you can't do that. So I feel that's one thing that makes ophthalmology really attractive to a lot of people. I wanted to ask you what advice you'd have for students and for medical students, pre-meds, and residents, for people who want to go into ophthalmology, maybe what they should be doing early on in their career, and maybe what they should be looking for in terms of their lifestyle and things like that when considering their specialty.
Wow, that's a really good question. So let's start with people that are in college trying to get into medical school. Don't worry at all about what you're going to do once you're in medical school and afterwards. That shouldn't, in my opinion, shouldn't be anywhere on your radar. I know it was for me, but forget me. Just focus on doing everything that you can to be competitive to get into medical school, because I believe, as I understood from one of your podcasts, it's easier to get into Harvard than it is an average Canadian medical school. That's amazing. But actually, that is the nice thing about medicine. And you hear all these horrible things, debt and reimbursement, all this. But the nice thing about medicine is you really only have one barrier of entry, and that's getting into medical school. Once you're on the other side, you're that small number of people that have gotten in, and then you're almost guaranteed success from there forward. If you put in the work, pass the tests, you can do it, and then you have this nice life afterwards. So all of your focus has to be, what do I need to do to get into medical school? What do I need to do to be competitive? I mean, you guys kind of know this already. How much volunteer work do I need to do? Do I need to do this? Do I need to do that? What kind of scores do I need to have? That should be your only focus after you've gotten into medical school. Medical school is great for training you in all the background information to give you the tools to go into residency. And it really, what it does is it teaches you how to think scientifically. So it's wonderful at that. But kind of the focus is showing you all the different areas of medicine and how to decide one thing or another. But it only gives you a few weeks to make that choice on each rotation, right? And this is a choice that's going to hit you for the rest of your life. And even the choices that they're showing you aren't realistic, because they're showing you what academic life is like. And academic life is nothing like private practice. So it's kind of this weird system, but there's no better system out there. So my advice for the folks that have just gotten into medical school is, once again, do not pick a specialty. You have to go through these classes with the idea that you could be anything. That means everything is important. There's nothing that you can blow off. You can't, say that genetics, I'm not going to spend a whole lot of time there, because you might turn out to be in genetic medicine. So, you have to keep a very open mind about it. And then once you're in your third and fourth year, you really have to start narrowing down, how am I going to spend my life? What are the quality of life things? And really, that's a great thing to look at, is to try and find somebody out in private practice and see how happy they are with what they're doing, whether or not they're doing anything other than medicine, whether they look tired all the time. Those are big indicators. From a financial point of view, really it all boils down to dollars per hour. And, you have a choice. No matter what field you go into, it's dollars per hour. You can either have time or you can have money, and you can't have both. And I know that sounds simplistic, but it really does come into play once you're through residency and out into practice. How many hours a day do I want to work? How important is it that I have XYZ versus I have time to watch my kids grow up?
Thank you. That's some very helpful advice for everyone out there who's pursuing med school. And I want to ask you, what propelled you to pursue an MBA, and would you recommend it to other pre-meds?
Wow, you guys ask really good questions. Would I recommend it to pre-meds? No, not unless that was going to help you in some way get into medical school. I wouldn't. The reason that I got an MBA, which I got later on in life, was because I was in academics at the time, and I was rising about as high into academics as I could go, and I wanted to be a chairman. And so the only way that I could get there was to have more letters after my name. So I went and became an MBA. And then I was fortunate enough to get my own department shortly after that.
I think that makes a lot of sense, especially when it comes to how difficult medical school is to get into in the first place. It's very difficult to sort of not put your eggs all in that basket as opposed to spreading them out. But I feel like, again, maybe my perspective on this is the sense that, like you said, being a person comes first as opposed to, being a doctor, right? So in that sense, maybe it is important for someone who does want to explore that pathway to potentially get involved in that stream of education if they so choose to want to learn more about that field. But I guess moving forward just into the realm of medicine, could you just elaborate a little bit more on some of the most challenging cases that you may have encountered and how you went about actually finding solutions for these patients, and maybe how you sort of imparted this wisdom to the residents that you taught as well?
Yeah, once again, great question. So the biggest thing that challenges us as glaucoma providers is convincing your patients that they need to do the treatments that you're recommending. Because, cataract surgery, as you've elaborated, they know they can't see. It's impacting their life. They can't drive at night, or they can't see the food on their plate. So they want the surgery, and you're going to do the surgery, and then you're going to help them get their life back to some degree, and they're going to hug your neck, and they're going to be happy, and all of these things, and it's wonderful. But when we're talking about glaucoma, we're talking about a slow, insidious, progressive, permanent blindness that's coming on that you can't appreciate because it's all happening way out here, right? And until it gets here, you don't know it, because we don't use this vision out here very often. So the patients don't know it. They're not aware of it. You're prescribing all of these drops that they need to take, and they don't want to do that because they can't tell any difference one day to the next. And you're looking at it in terms of years. You don't want them to come back in 10 years and be blind, but they have a hard time seeing that. And so it's hard to remember to take eye drops anyway. And most of your patients are elderly, so it's hard to do all of that. So that is our biggest challenge, is what's called compliance, and that is doing the eye drop regimens that you prescribe. So what's the solution to that? You've got to do a lot of education, but more than that, and this is what I teach my residents, you have to win the patient over. It's called a clinic visit for a good reason. You have to visit with your patient. You have to get to know them, and the secret is talk to them about anything other than medicine for a couple of minutes. figure out what their kids do, figure out what they like, what are their hobbies, tell me about the cruise that you've just been on. You have to see them as a person. If you have this get them in, get them out mentality, they're going to pick up on that. I think that the longer you're in medicine, the older you get, the more that you've been a patient, and you can see how long you're sitting in somebody's waiting room, and you sit there and think, well, how long did my patient sit in my waiting room waiting on me? And so then you go back and you want to make that shorter. You want to make it as pleasant an experience, almost like they want to come to the doctor and talk to you and tell you, because once they're on your side, they're going to trust you, and they're going to increase their compliance by what you're doing and what you're saying. And so you give them lots of photographs of their drops so that there's no confusion. You show them models of the eye. You explain over and over how glaucoma works. You use analogies. I use an overflowing sink with a clogged drain as an analogy for glaucoma. Everyone kind of understands that, and what the treatments are on the different parts of whether we're going to turn off the faucet or we're going to try to unclog the sink to help you get better. That they understand. So there's no need for a lot of medical jargon. So you use analogies, you become their friend, and it really makes your job easier and a lot more fun when you're just taking care of friends instead of patients.
Yeah, even when I've been a patient and a doctor talks to me just for 5 minutes about my life, it's so much more different than a doctor just coming in, get on the table, see what's wrong, and then they get out. And I know it can be hard for a lot of doctors because here in Canada, at least, a lot of it is based on how many patients you're seeing. And I presume that it's like that in the US as well. So people just want to bill as much as they can in the hour. And that's what kind of leads to this mistrust in the healthcare system sometimes. So I think it's really important to spend that time and invest that into your patients because it'll pay off in the long term, as you were talking about. We alluded to this earlier about some of the rewarding aspects of your work. So I wanted to ask you what you find most rewarding and how you tend not to burn out, which you were talking about earlier as well.
So, yep, another great question. So the things that are most rewarding are just day-to-day visiting with the patients who I've gotten to know, because with glaucoma, they're coming back a lot. There's a lot of repeat business because you never get over glaucoma. So you really get to know the patients, and that is absolutely the most fun. It's kind of, when you're younger, it's fun to learn all the stuff and, what's this disease, and, oh, this is kind of weird pathology and I'm enjoying seeing this, and that's all kind of cool stuff. But, after a while, you've kind of seen a lot of stuff, I wouldn't say everything because you've never seen everything, but after a while, it just gets to be about the patients, and that's very rewarding. And that's what brings you back day to day. You really care about your folks.
Thank you, Dr. Wiggins. So just to end off the podcast, we have a fun little game that we're going to play. We have some statements prepared related to eye and vision, and we want you to tell us if it's a common myth or a truth. So we'll just list them, and then you can go ahead and tell us if it's a myth or a truth, and then provide some explanation. So the first statement we have is, reading in poor light will hurt your eyes. So is that a myth or truth?
That's a myth. So think of your eyes exactly like a camera. So if you take a picture in a dark room, it does no damage to the camera. The image may not be what you want, but it doesn't hurt the camera. Same thing sitting too close to the television. Your mom didn't like it, but it doesn't hurt you at all.
That's a very important point that you brought up. I'm going to go and tell my mom this right after I'm done. And you actually also answered one of the other questions we had. So I'll ask you another one. What about wearing eyeglasses that are too strong or have the wrong prescription will damage your eyes?
Wow, that's a really thoughtful question. So and the answer is it depends. So we have two kinds, and I've taught optics for a long time. So we have plus lenses and we have minus lenses for people that are farsighted and people that are nearsighted. If you have lenses that are 2+, doesn't hurt you whatsoever. If you have lenses that are 2 minus, then you've got to contract the muscles inside of your eyes to kind of see better. And that can give you chronic headaches. And so, although it doesn't permanently damage you, it gives you chronic headaches. And who wants that?
Okay, so our next statement is your eyes can get sunburned. Is that true or is that false?
Completely true. So, every once in a while, you'll come across an unfortunate individual who got high and stared at the sun, just laid there and stared at it. And it's called solar retinopathy, and it does burn a spot into the back of your retina. And oftentimes that's permanent, and they'll have this black gray spot in the middle of their vision, and there's just nothing you can do about it. It's like it's damage to the film of the camera, and it is what it is. So yes, you can. And that's why lasers can do the same thing.
Will eating carrots improve your eyes?
So that's a good question. There is some evidence that what's in a carrot is good for you, but will it improve your eyes? No. But eating a healthy diet is always good because that's what the photoreceptors in your retina need. And also anything that can keep your blood pressure well controlled, because you need good blood flow to the eye. So things that aren't building up plaques in your bloodstream, that sort of thing, are always good. So exercise, always good for the eyes.
And our last one is actually, I am colorblind. It's a fact that not many people know. And whenever I tell anyone, they're always like, I've only met guys that are colorblind. I never met any girls that are colorblind. So the statement that we're going to ask you is, can only boys be colorblind?
Well, there are different forms of color blindness. And in red-green color blindness, it's carried on the Y chromosome. So there you go.
I see. Well, I do have red-green color blindness, so now I know the reason for my predicament, I guess.
All right, guys, with that, we'll bring the podcast to the end. We've learned everything from ophthalmology to Dr. Wiggins' early career and late career in ophthalmology. So, Dr. Wiggins, we want to thank you, and we want to let the viewers know that there's an upcoming novel coming out, The Letters of Arkansas Traveler, and we'll leave more in the description below, so make sure you guys check that out. Thank you, Mr. Wiggins, for making time, and we'll see you guys in the next podcast.
Thank you so much for having me. Really enjoyed it.